So if you inherited from mom and dad the ability to not make PCSK9, these people have what we call hypo-beta lipoproteinemia. They go through life with LDL cholesterols of 5, 10, 15, max of 20, 30. And they have no incidence of heart attacks as farther time goes by, but they suffer no consequences of low plasma LDL cholesterol or plasma ApoB. What is the single most prevalent cardiovascular morbidity mortality in diabetics? Atherosclerotic heart disease, myocardial infarction, heart failure, strokes. We're wiping out heart attacks and strokes and all the other endpoints of cardiovascular disease in these people. So it is absurd to stop a statin because glucose is going up, unless you care not about atherosclerotic vascular disease. Please.
Welcome back to another episode of Foolproof Mastery. I'm your host, Patrick Razorov. Today we've got the third part of the Heart Disease Masterclass with Dr. Tom Dayspring. In this part, we're going to focus on the different types of heart disease medication. You're in for a big treat. Enjoy. I'm just going to give a little bit of a short wrap-up of what I've learned from the many podcasts with you. I don't want you to repeat the same information. Hopefully, I've understood the majority of what you've talked about correctly. First of all, with regards to dietary cholesterol, some people may be hyperabsorbers. So this could be due to problems with the Niemann-Pick C1 protein. Maybe I'm saying it incorrectly.
You are.
Well, you'll tell me how it is correctly after. So some people may be able to eat 20, 40 eggs, you said, and have no effect on their LDL cholesterol, while others may. Bile acid sequestrants were the first sort of drugs used to treat high levels of cholesterol, and the liver starts producing more bile from LDL to make up for the binding to the bile acids. Correct me if I'm wrong there. Phytosterols and Stanols. Certain people may have dangers of having too much of an intake in phytosterols if they're hyperabsorbers, whereas Stanols cannot be absorbed. There's some foods such as benecol, which has been developed from Finland, which works in a similar sort of way. You can buy it in the shops. It's a yogurt. Ezetimibe helps to block cholesterol from being absorbed. On to statins, they reduce the pool of cholesterol in the liver by creating more LDL receptors to take out ApoB from the blood. The two main side effects are either muscle pains or reduced insulin sensitivity. But even for people with diabetes, the risks does not merit not taking a statin. The statin still helps the overall health outcomes. Other LDL lowering drugs such as PCSK9 inhibitors, it's to do with increasing the lifetime of the LDL receptors on the liver. You take them by injection, which hasn't really got side effects. And you also said that PCSK9 inhibitors can be also used to lower Lp(a). Some people with genetic conditions can have this particle, which is particularly atherogenic. Some drugs manage to lower ApoB, such as niacin, estrogen, red rice extract, without having an impact on heart disease related deaths. And then finally, the impacts between having one drug compared to taking two drugs, such as a statin, which improves the amount of LDL receptors. And then you have something such as Ezetimibe, which blocks the absorption of cholesterol from the intestine. So that was a rough guide of what I've learned.
Well, you certainly ask a lot of things, and to thoroughly understand those would require several hours of additional podcast, both on the absorption of cholesterol. There are a couple of major lipid textbooks where I've written 30-page chapters on how sterols are absorbed. And so it's very complex. So I got to try and narrow this down as much as I can. So, as I hinted earlier, that cholesterol is an essential molecule. So evolution gave every cell the power to de novo synthesize it, but it also gave our the ability to absorb it. So a little bit about the absorption that occurs. So absorption means something that's in your small intestine is going to work its way into the cells that border the lumen of your intestine. They're called enterocytes. And then that enterocyte has to package whatever the heck it absorbed into a way that it can release it into the body, so whatever it absorbed can wind up elsewhere where it's really needed. And I've hinted to you that the way that an intestine primarily gets rid of any lipids that is absorbed is it packages them in this big fat balloon called the chylomicron, which then gets released into the lymphatics, into your circulation. So part of the components of the chylo is going to be cholesterol, triglycerides, and phospholipids. So the main source of those three lipids is, hey, they're sitting in your intestine right now. The enterocyte has to decide to let how much of whatever come in. And sometimes if the intestine makes a mistake and oh my God, we let in too much, especially cholesterol, evolution has given that enterocyte the ability to, you absorb too much, throw it the hell out back to the gut lumen. So that one process would be influx of cholesterol, and the other would be intestinal efflux of cholesterol. Now, remember, any cholesterol in your gut that doesn't get absorbed is going to keep traveling through your intestine and wind out in your feces. That's called fecal excretion of cholesterol. And that is the second way by which the most frequent way by which the body gets rid of cholesterol, puts it in your stool. So, okay, we'll get to how that happens. The first question is really, if we're going to talk about sterol absorption, notice I said sterol absorption, not cholesterol. Sterols are a group of very like molecules that have incredibly similar biochemical structure, but each specific sterol has a slightly different molecular arrangement of some of the side chains that comes off the, what we call the aromatic portion, the ring portion of the molecule. So there is cholesterol, which I said essential for human life. And then there are 100 other types of sterols, but they're not cholesterol structurally. They look like it, but a biochemist would say, you're not cholesterol. You're like a brother of cholesterol. You have a similar structure, but you're not cholesterol. Those are collectively called non-cholesterol sterols. They're like cholesterol, but not really. But the only molecule your body can use for essential substances is cholesterol. So non-cholesterol sterols might have other functions, but they're certainly not needed for your cell membranes or for a lot of other tissue functions. So if I look in the, what makes up that non-cholesterol sterol group? By the way, another word for them, sterols that are not cholesterol, there are other types of sterols. So collectively, they should be called xenosterols. So you have cholesterol and you have a whole group of xenosterols. One of the subgroups of the xenosterols came from something you ate called plants. Plants, like humans and animals, need sterols for their cell membrane, but plants don't, for the most part, rare exceptions, don't manufacture cholesterol. They manufacture sterol that looks like cholesterol, but it's not. And there's 20 or 30 of them. They're called phytosterols, of course, because plants make them. All right. But we eat plants, most of us. So every time you eat a piece of lettuce or broccoli or celery, you're putting phytosterols in your intestine. If you eat meat or eggs, you're putting cholesterol in your intestine. And all of a sudden, your intestinal lumen is going to be filled up with sterols, cholesterol, and the xenosterols, the non-cholesterol sterols, most of which are phytosterols. Now, your liver your intestinal lining, the enterocytes, knows, hey, we have to let some sterols in, but they were engineered through evolution to recognize the cholesterol molecule, and that gets preference on internalization into the enterocyte. The enterocyte has a specific receptor that it expresses that has a high affinity for the cholesterol molecule. You've stumbled on it. It's called the Niemann-Pick C1-Like 1 protein, NPC1L1. So that, if that sticks out of your enterocyte, It sees all the cholesterol in your gut lumen, and it grabs it and it pulls it into the enterocyte. All right. But what about the phytosterols that might be sticking you or floating around your intestine? It's a great receptor, Niemann-Pick, and it has a high affinity for cholesterol, but it's not the super brightest receptor. So by mistake, some phytosterols will make it into your enterocyte. So yes, thank God it's absorbing cholesterol. I wish it didn't, but it's also absorbing some phytosterols. No human needs phytosterols for the simple reason we're not plants. We have no use for phytosterols. No human can synthesize a phytosterol. So why do you think evolution didn't really want phytosterols to be absorbed? I would tell you in the long run, they're probably toxic once they exceed a certain concentration anyway. But some do get in. This is where the defense mechanism of the enterocyte comes into play. Because of nuclear transcription factors in the cell, it says, oh my God, this receptor pulled in some phytosterols. The two most common known are campesterol and cytosterol, but there are many others. And that gene, it says, oh my God, there's too many phytosterols in the enterocyte, then transcribes a protein that makes a sterol efflux transporter, ATP-binding cassette transporter, G5 and G8. Together, they become what's called a heterodimer. They work together. They're expressed on the surface of the intestinal cell, and they take any phytosterols that got in, and they evict them right back out to the intestinal lumen, and then you can excrete them in your feces. So if you have normally functioning NPC1L1 and ABC G5, G8, and there are genetic tests for them if you want to do it, but you don't really have to. If they are working harmoniously and in balance, virtually no phytosterols will ever be seen in your blood. Interesting, though, that ABCG5G8 also helps regulate cholesterol absorption. Because suppose the Niemann-Pick just pulled in way too damn much cholesterol, more than the body needs. The ABCA5 says, whoa, we're going to revict some of the cholesterol right back to the gut lumen because we don't need that much. So NPC1L1 pulls them in and ABCG5G8 effluxes them out. If you have perfect harmonious function of both of those, you have perfect cholesterol absorption. If one is hyperfunction or hypofunction or vice versa, you're going to have hypoabsorption or hyperabsorption of sterols. And that's not good because if you have too much cholesterol coming in, it's going to go to your liver. If your liver is getting a lot of absorbed cholesterol, the liver stops making LDL receptors because it doesn't want any more cholesterol. It doesn't want to clear any cholesterol-containing ApoB particles. So ApoB goes through the roof if you're a hyperabsorber of cholesterol. You could say, God, if we could only reduce absorption of cholesterol, the liver would get less of a delivery of cholesterol. That would make the liver express and grow more LDL receptors, clear more ApoB particles. You stumbled over the drug that does that, Ezetimibe, Ezetimibe is the generic name. In the United States, the brand name is Zetia. Different parts of the world, it has other names. So Zetia became, which hit the market around 2001, 2002, became a wonderful, nice addition to the ApoB lowering family of drugs with a specific mechanism of action, blocking cholesterol absorption from the gut. Here's where this story gets a little more complicated with respect to diet. Because as I said, there are foods that you can eat that are full of cholesterol. The problem is the food you eat, there's two types of cholesterol. There's one type of cholesterol. If you just have the cholesterol molecule, that is called free cholesterol. It's cholesterol into itself. The overwhelming majority of cholesterol that we eat, or that is made and stored in our cells, has a fatty acid attached to it. So when cholesterol is a sterol alcohol. When you attach a fatty acid to a sterol alcohol, that process is called esterification. Cholesterol changes to something called cholesterol ester. It's a much bigger cholesterol molecule. super hydrophobic because it's fats on both sides of the molecule. So most of the stuff you eat are cholesterol ester. Now, when it gets down to your intestine, your pancreas, look, you've eaten triglycerides too. They cannot be absorbed. They're monstrous. But your pancreas says, uh-oh, there's fats in the intestine. So the pancreas releases a bunch of hydrolytic enzymes that dissolve esters. Triglyceride is three esters on a glycerol molecule. So lipases are made by the pancreas. And on cholesterol ester, they separate the fatty acid. You're returned to free cholesterol, the only type of cholesterol that can be absorbed by the Niemann-Pick C1-Like protein. Cholesterol ester, if it doesn't get deesterified, will pass right through you, cannot be absorbed. Fortunately, most of us make enough lipases to deesterify the cholesterol ester. This similar but different lipase would hydrolyze the fatty acids off of triglycerides. So although the triglyceride cannot be absorbed, the released fatty acids can be by a very different receptor that has no relationship to Niemann-Pick C1-Like one. The receptor that pulls in fatty acids is called CD36, cluster differentiation protein 36. So a big mistake is doctors think everything gets absorbed by the same mechanism. No, sterols have one mechanism, Niemann-Pick and ABC G5G8. Fatty acids have other mechanisms to get into the enterocyte. So the only absorbable cholesterol molecule in your gut is free cholesterol. You might have eaten it and it got deesterified. That turns out to be about 30% or less of the cholesterol that is in your or my intestine right now. So where is the other 80% of cholesterol, 70% that is sitting in your gut right now? How the hell did it get there? You didn't eat it. It's what connects the liver to the intestine. That's called our biliary system, our bile ducts. So when the liver has extra cholesterol, it says, I'm sending you right into the bile. You're going to go down right to the intestine, and hopefully the intestine will poop you away because I don't need you anymore. So about 70 to 80% of the potentially absorbable cholesterol, free cholesterol in your gut, is of hepatobiliary origin, not ingested origin. So if you're going to block cholesterol absorption with a drug like Zetia or Ezetimibe, understand that you're basically blocking the absorption of internally endogenously produced cholesterol that got returned to the gut via the liver and the bile, and it's going to come right back in unless you block. So a little bit of the absorbed cholesterol, of course, will be absorbed too, but the overwhelming majority of cholesterol molecules that are being absorbed were put there because they were produced internally and the liver was trying to get rid of them. And that's why, except in extreme hyperabsorbers of cholesterol who have a loss of function of ABC G5G8, so they can't get rid of overabsorbed cholesterol, the amount of cholesterol in the diet is irrelevant. If you are a normal absorber of cholesterol, I'm not going to tell you to reduce cholesterol in your diet if you like it. But if you're a hyperabsorber of cholesterol, that would be the person I say, we do have to restrict the cholesterol in your diet because you're just absorbing way more cholesterol, be it of hepatobiliary origin or ingested origin. So there are blood tests that tell us who are hyperabsorbers or not. It could go to gene root, but still you're going to have to, no matter what your genes are, that would tell you the likelihood that you're a hyperabsorber. But there's a blood test that would tell you exactly are you or are you not. And just to get that out of the way, you're not supposed to absorb phytosterols. You are supposed to absorb cholesterol. If I measure cholesterol in your blood and it's high, I don't know whether you absorbed it, you synthesized it. I have no clue where it came from. But what should never be in your blood? Phytosterols. So if I do a phytosterol blood test on you, it's campesterol or cytosterol, most commonly done, and their levels in the blood are starting to go up a little bit, I know your absorption mechanism is broken. You're absorbing too many phytosterols. And if you're absorbing phytosterols, it's a given that you're way hyperabsorbing cholesterol also. So if your plasma levels of cytosterol or campesterol start to go up, almost certainly your ApoB is going up because you're absorbing too much cholesterol also. So a great therapeutic choice to lower ApoB is to block the absorption of cholesterol with Ezetimibe or Zetia. And by the way, that also blocks the absorption of phytosterols. And there's a very rare disorder where people just don't make ABCG5 at all. So that means they absorb every phytosterol that makes its way to the gut. They have massive levels of phytosterols in their blood and suffer severe consequences of different organs in the body. Now, that's 1 in a million have that. That is, before Zetia was invented, there was not a great way to treat those people. Zetia can now help those people a lot, but that's rare. So the main reason that we measure phytosterols in the blood now are to get a handle. Is part of this patient's cholesterol pathophysiology hyperabsorption? If it is, I have a great solution. So you must understand that most of the cholesterol in your gut was produced internally. It's not the major driver of atherosclerosis is you're not eating 12 eggs a day. That would only be harmful in a hyperabsorber who has screwed up Niemann-Pick ABCG5G8 balance in their liver. Most people don't have that imbalance, but it's easily measurable by those blood tests. The last thing, because you did throw out the word stanol there. Now, cholesterol, OL means alcohol in biochemistry. And if I look at cholesterol, or any of you Google it, you'll see the structure. It's 5 rings with a tail. In the first ring, in the second ring, there's what we call a double bond. Normally, carbon atoms are saturated with hydrogen atoms, but if they're not, it's called a double bond situation. So cholesterol has 1 carbon bond that is not saturated, and that's a very unique property of cholesterol. It's one of the things that the Niemann-Pick is looking for to absorb cholesterol. But if somehow we had cholesterol that lacked that double bond, that's called cholestanol. So a stanol is basically a saturated sterol. So a sterol becomes a stanol. So when the Niemann-Pick is looking at molecules to absorb, number 1, it'll grab cholesterol. Number 2, it'll grab phytosterols. What it has almost zero affinity to bind to and internalize are stanols. So any stanols that wind up in your gut are going to be excreted in the stool. So this is kind of cool now. Let's get back to, hey, you hyperabsorb cholesterol, the ABCG5G8 in the enterocyte, efflux the cholesterol right back to the damn gut lumen. What would prevent you from just reabsorbing it again? Your gut microbes. Those bazillions of bacteria sitting in our gut have the unique ability to take cholesterol, saturate it, and change cholesterol into cholestanol. So if ABCG5G8 evicts cholesterol and our bacteria cooperate and immediately saturate the evicted cholesterol, changing it to cholesterol, it's going to wind up in your feces tonight, and you're going to excrete it. And this is the principle with the manufacture of that compound called cytostanol. Cytosterol is a phytosterol that we shouldn't absorb, but if we do, we can measure it in your hyperabsorber. But if a manufacturer could desaturate cytosterol, changing it to cytostanol, and then give it a cute name like benecol, if I swallowed benecol, it actually ties up with our bile acids the ability to traffic cholesterol to the Niemann-Pick. So stanols can reduce to a small degree the absorption of cholesterol in our gut. So that's where you use this supplement, benecol. There is a margin. There used to be crackers or chips you could eat. And at the end of the day, you're going to absorb less cholesterol. You might reduce ApoB, LDL cholesterol by 5%. So it's a little bit of a helper. If you have a serious ApoB elevation, it's not going to be the total solution to controlling your ApoB. But it's one of it's in our armamentarium of cholesterol absorption reducers. So that's the cytostanol, the stanol sterol story. So It's very complex, as you can see. The last little pearl I'm going to give you, if cholesterol or phytosterols makes it into your enterocyte and the ABCG5G8 is broken and it doesn't evict the phytosterols, and all of a sudden your intestine has more cholesterol than it really wants to put in a chylomicron, there's another escape route from the enterocyte into the blood. Everybody thinks chylomicrons are taking all the lipids out of the intestine, and they do the majority. Certainly they do all of the triglycerides and a lot of cholesterol too. But the intestine can also express on its interface with the blood, that's the other side where it interfaces with the lumen of the gut, a transporter ABCA1, which I think I mentioned in the earlier parts of my lecture. So you have a sterol efflux transporter in the gut that sends cholesterol from the enterocyte into a cholesterol acceptor, ApoA1, or HDLs. So our HDLs are involved with the absorption of cholesterol from the gut also. There's always redundant methodologies when evolution constructs our cells. Gives you always a couple of routes of doing things. So believe it or not, when you see people with high HDL cholesterol, but their LDL cholesterol is also elevated, at least one of the things you should think of is I'm dealing with a hyperabsorber of cholesterol, because the intestine not only put too much cholesterol in the chylos and send it to the liver, it's overfilling my HDLs, which will go do whatever the hell they want to do with it. As you know, they have many avenues where they can bring that. So it's very interesting that HDLs are involved with cholesterol absorption too. Basically, don't ever assume that because HDL cholesterol is high, there's hyperabsorption. Number one, look at ApoB. And number two, maybe do these more sophisticated blood tests that I'm talking about. Now, listen, this is a global podcast. Maybe, I don't know. In the United States, it's even getting hard to find a laboratory that will report these xenosterols to you, the absorbed cholesterol. But there's a couple of big labs that do. So in the practice I'm in, we get those measurements on every single patient. But not every doctor even knows of these biomarkers. And even if they got them, they wouldn't know what to do with them. So you can see there's handicaps. But that is a very easy way to know who's a hyperabsorber or who is not. Measure phytosterols in the blood. So that's sort of the intestinal side. And by the way, if Zetia blocks cholesterol absorption, your liver is denied a source of cholesterol. It manufactures and expresses more LDL receptors. You clear more ApoB particles. Thank you, Ezetimibe. And that's why it's a wonder. Now, the ability of Ezetimibe to lower ApoB LDL cholesterol is in the 15 to 20% range. There are other drugs that can lower it a lot more, but you can see Zetia becomes a useful adjunctive add-on therapy to whatever you might have started with. Unless you're like me, you know, day one, oh my God, you're a hyperabsorber of cholesterol, then Zetia would become my first-line drug in that patient. Most clinicians don't have that information, so they tend to use Zetia as a secondary add-on drug or a primary add-on drug day one if you're a total ApoB nightmare and you know your statin is not going to get you to goal. So that's enough about absorption, I think, for you. You can see it's very complex, and I've left out a lot of steps. With respect to the therapies you mentioned, basically niacin and the fibrates, they lower ApoB because they inhibit triglycerides in large part. The less triglycerides you make, it's easier for an LDL receptor to clear LDL particles. So they have some ability to lower ApoB. The fibrates can do that. There's very little toxicity to it. Niacin has so much toxicity, nobody uses it anymore. And we also know what it does to HDL cholesterol, or even what fibrates do to HDL cholesterol is meaningless. So those two drugs have fallen out of niacin. Certainly prescription niacin is off the market in Europe, and it should be off the market in the United States. Very few people use it anymore. All right, so statins, quickly. They inhibit cholesterol synthesis. In every cell in your body that a statin gets into, you will reduce cholesterol absorption. You know, you never want to overdo that too much because cells do need to make X amount of cholesterol. But the organ in your body that produces the most LDL receptors that are going to clear these potentially bad ApoB particles is the liver. So if we can really inhibit cholesterol synthesis in the liver, you deny the liver a source of cholesterol, it will manufacture and express more LDL receptors. You will clear more ApoB particles. Simple as that. So statins, by inhibiting hepatic cholesterol synthesis, you express LDL receptors. They lower ApoB, and depending on which statin and which dose you use, 25 to 40 or more percent. So they, until the somewhat recent future, were our major league ApoB lowering drugs. And once Zetia came along, we found that, oh, fantastic. If the statin didn't work, we can add Zetia to it. You mentioned a couple of potential downsides to statins. If you look at the serious trials that have investigated this in every possible, maybe 5% of people will get a muscle ache with a statin, and they just say, I'm sorry, I can't take this. My muscles are achy or they're a little weak. So then we have to find out a different ApoB solution. Now, about 20% of people will complain of something when you put them on a statin, including muscle aches. And it's just what we call a nocebo effect. It has nothing to do with the statin, but that's tough to convince a patient who's telling you this is bothering me, that, and it's all since I started the statin. They're reluctant to continue the statin. But the proven muscle aches are a real minuscule number of people who are on the statin. And remember, if you go to guidelines, who you're really prescribing statins are for super high-risk people who either have had heart attacks or are going to have heart attacks. We're not putting statins in the drinking water for people who don't have ApoB issues. So used appropriately, if we gave them to 10,000 people over 30 years, you will reduce way more heart attacks and strokes than you will ever cause muscle aches. So benefit versus risk. But heck, if you're a patient that says, my muscles are barking, thank God we have other ways of lowering ApoB nowadays. We didn't always have that, so it was tough. All right. The other thing that we see with statins is, oh boy, there seems to be a somewhat increase of prediabetes and diabetes in people who take statins. In retrospect, we know it's pretty much the obese, insulin-resistant people who already have, if not prediabetes, they have all the metabolic markers of insulin resistance. And in them, statins seem to increase glucose levels. And you know, if your glucose exceeds 100, I could call you a pre-diabetic. If it exceeds 126 milligrams per deciliter, I can call you a type 2 diabetic. So yes, in the statin trials, X number of people, you know, the relative risk might be 20, 25% that we see glucose exacerbations. Funny, though, if you pick down every diabetic guideline by the ADA, the colleges of endocrinology, they all pretty much mandate statin use in diabetics and even pre-diabetics, because what is the single most prevalent cardiovascular morbidity mortality in diabetics? Atherosclerotic heart disease, myocardial infarction, heart failure, strokes. So they say, you know what? We may cause X number of people to have slight escalations in glucose that technically you could say they're a diabetic, but we're wiping out heart attacks and strokes and all the other endpoints of cardiovascular disease in these people. The benefit is worth the risk. We can also monitor the glucose. And if it does get to a level you don't like, we got at least 10 other ways of lowering glucose in the body without saying you have to stop the statin. So it is absurd to stop a statin because glucose is going up, unless you care not about atherosclerotic vascular disease, please. So that's the story there. You monitor people on statins, you keep an eye on it. Should it occur, you take care of it. The first step might be a little dietary adjustment, for goodness sakes, in those people. But there are therapeutics that can not only make your glucose better, but in addition to whatever the statin is doing, reduce heart attacks and strokes. You know, we have a big group of therapeutic molecules in our diabetes armamentarium nowadays. The next drug, and I'm going to talk about this before I get to the PCSK9, more recently introduced drug called Bempedoic acid. Like statins, it also inhibits the synthesis of cholesterol. Cholesterol synthesis is 37 steps. The statins inhibit the third step, the major step. The bempedoic acid inhibits the first step. So, yes, it's a cholesterol synthesis inhibitor, but not to the extent statins are. which means, yes, it can deplete synthesis of cholesterol only in the liver, because the enzyme that activates that drug only exists in the liver. So if you take bempedoic acid, it doesn't stop cholesterol synthesis in your brain, your muscles, or any other organ in your body. So it's hepatoselective. Great news. That means there's no muscle aches with bempedoic acid because it's not interrupting cholesterol synthesis in your muscles like a statin can. The problem is, hey, how much will it lower LDL cholesterol ApoB? 10, 15, 20%, depending on the degree of synthesis. So it's an adjunctive drug to add on to statins. You can add it to Zetia. A couple of manufacturers make combinations of Zetia and bempedoic acid in the same pill. In the United States, by the way, bempedoic acid is called Nexletol. The combination product with bempedoic acid and Zetia is called Nexlizet. So, you got two pills in one tablet. So it just is another addition to our therapeutic armamentarium. There's not a very minuscule number of people on bempedoic acid get slight escalations in their uric acid level. So it should not ever be given to a patient who has had gout or severe degrees of hyperuricemia. That is not most people. In people who haven't had gout or really high levels, you can always monitor uric acid in the blood to make sure you're not screwing that up with bempedoic acid. But it's not a majorly concern, but you should know about it. That's for sure. So interestingly, just released this week, it hasn't been published yet, was in the United States, the drug company Aspirion makes it. And they're doing a major league outcome trial of 20,000 some patients. And they reported that the trial is successful. The drug does reduce heart attacks, blah, blah, blah. We'll get the final data probably in the spring when it's published so we can fine tune it and adjudicate it. But it joins the list of other LDL receptor expressing drugs that reduce heart attacks. So great news for the bempedoic acid people. It's a proven add-on therapy now to whatever you're using. Interesting, the trial, they enrolled high-risk people who couldn't take a statin. So they gave them bempedoic acid only, and it worked by itself. That's nice. So I imagine if you could take a statin and bempedoic acid, it would work even better. That's hypothesis right now, but it's like Zetia and statin is better than Zetia, which has been proven in other trials now. So finally, and there's not a lot of downside to the bempedoic acid other than what I said. All right, but if you really got a nightmare ApoB and you want to get it down, I have to so maximize the LDL, number of LDL receptors that your liver is exposing, because the more LDL receptors, the more ApoB particles you can pull out of plasma. Most of those particles are LDLs. So bempedoic acid and statins inhibit the hepatic pool of cholesterol by interrupting synthesis. Zetia blocks the hepatic pool of cholesterol by blocking absorption. And in response to those drugs, you upregulate LDL receptors. When an LDL receptor grabs an ApoB particle, it internalizes it into the liver and it catabolizes the receptor. So can we make LDL receptors live for another day? So when the LDL receptor attaches to an ApoB particle, most are LDLs, but some VLDLs also, it pulls them into a cellular subparticle called a lysosome, which actually destroys the ApoB particle. And in many cases, it destroys the LDL receptor too. But fortunately, a lot of us, the lysosome releases the LDL receptor so it can migrate back to the blood surface of the liver and grab more ApoB particles. If we could enhance that process, we would be extending the half-life of an LDL receptor in the liver. That would be good, because the more LDL receptors you have, the lower you're going to reduce ApoB by clearing all those particles. So there's a protein in our cells that regulates the catabolism of LDL receptors, and it's called PCSK9, protein convertase subtyrosine kexin type 9. Oh my God, who thought up a name like that? But anyway, we're going to say PCSK9. PCSK9 will determine whether that LDL receptor gets destroyed or lives for another day. So if we could somehow reduce the amount of PCSK9 or prohibit its synthesis, wow, your LDL receptors would recirculate far more than they do now. You would have way more LDL receptors. You will really lower ApoB. A PCSK9 inhibitor can lower ApoB, LDL cholesterol 50 and even higher percentage. Even more so if you combine it with a statin, Ezetimibe, or Bempedoic acid. And the nightmares of the world, we have to use multiple therapies sometimes, the people with genetic lipid disorders. So PCSK9 inhibitors. Right now we have 3. The first 2 were brought, once they understood genetically what PCSK9 does, we know we got to inhibit it. They made an antibody. Antibody binds to proteins. So if you make an antibody to PCSK9, it'll be bound up and it can't work anymore. So the first 2 products that came on the market, alirocumab, evolocumab, they have different brand names, will inhibit PCSK9. Your LDL receptors will live for another day. They're called LDL extenders, and they dramatically lower ApoB. Now, that is not an oral drug. You have to inject yourself. This is an evolocumab pen. I use it myself. So every 2 weeks, because thank God it has a long half-life, it's a very tiny needle. It's a subcutaneous injection. This is an auto pen. You just press a button and it self-injects. Takes 3-4 seconds, painless. And every 2 weeks, you mark your calendar, hey, take another PCSK9 injection. So those are the 2 antibodies, and you get these dramatic reductions. And now they also have clinical trials showing not only does it blow your ApoB and LDL cholesterol around, it has outcome evidence. You reduce cardiovascular endpoints. Super. So that is the great news. In the trials, and remember, most of the time, these were given to people who had heart attacks, very high-risk people. They've sort of shown that if you get the ApoB, the best results are if you get the ApoB down to about 35, the LDL cholesterol to 35, which is what you should be doing in very high-risk people. There are some people who respond so well to these, you make their LDL cholesterol 5, 10, or 15 milligrams per deciliter. And people, oh my God, no. Guess what? There is zero downside. They've done extensive cognition trials on these people. Nothing bad is the consequence. And we knew this was going to be true. And this is from the Mendelian, the genetic studies. There are some people who are blessed. They've picked the right mom and dad, and they inherit the ability not to synthesize PCSK9. That's called loss of function of the PCSK9 gene. So if you inherited from mom and dad the ability to not make PCSK9, these people have what we call hypo-beta lipoproteinemia. They go through life with LDL cholesterols of 5, 10, 15, max of 20, 30. And they have no incidence of heart attacks as farther time goes by, but they suffer no consequences of low plasma LDL cholesterol or plasma ApoB. So the genetic model is safe. And so this is why...
Just to interrupt, they experience no brain shrinkage, no vitamin D deficiency, no low testosterone.
Not with the genetic loss of function of PCSK9, none. And in the trials with the drugs that we have several years data where at baseline people underwent sophisticated cognitive testing, and many years later they did it again, and there was no signal of cognitive impairment.
With an LDL
and why
of 10.
should there be? Because the brain doesn't get cholesterol delivered from the periphery. The brain makes all its cholesterol. So again, the morons of the world who are out there scaring people that if you lower plasma lipid metrics, you're hurting the brain, are uneducated, if I can be polite, without calling them morons. And the genetic... Listen, there's another example. We talked about absorption, that Niemann-Pick C1-Like protein. What if you are born with loss of function of the gene that controls that receptor? That means you won't make that receptor. You will not absorb very much cholesterol. You will have significant lifelong hypoabsorption of cholesterol. Guess what? They have markedly reduced incidence of heart disease throughout life, and they have zero downside to their lower LDL. Now, they don't lower it as much as the PCSK9 inhibitors do, but it just goes to show you there are many causes of hypo-beta lipoproteinemia, hypocholesterolemia that have no downside to them. There are some that do, but certainly not with PCSK9 inhibitors or Zetia or anything that works through Niemann-Pick. So it's just an old idiotic premise. Like in my lecture today to you, we've discussed a lot of old idiotic premises, like raising HDL cholesterol is good, like HDLs are the only thing that do reverse cholesterol transport, like your gonads need LDLs to deliver cholesterol. It's just nonsense. And God knows in 10 years, we'll be even smarter on this, and we'll have other therapeutics. So that's the great. Now there's now a third PCSK9 inhibitor available to us. Interesting, it's not a monoclonal antibody. It's a drug that's attached to something that immediately after you inject it, it goes to your liver, and it inhibits a type of RNA that's involved with the synthesis of PCSK9. It's called an siRNA drug. And that, if you're on that PCSK9 inhibitor, your liver loses the ability to manufacture PCSK9. Which means if you're manufacturing less PCSK9, your LDL receptors are going to live a lot longer than they would if you were manufacturing it. So that is the generic name. It's called Inclisiran. In the United States, Leqvio, Leqvio is the brand name. But here's the beauty. Once it gets into your liver, it hangs around for 6 months through, you'd have to get into RNA mechanisms to understand it. So that drug only has to be injected every 6 months, which will drastically help compliance with people who don't want to inject something every 2 weeks. Very good for busy people who are traveling all the time and therefore don't have to take pens through security at airport because they're only getting this medication every 6 months. So those are the three PCSK9 inhibitors right now. And the final part of your story, you asked about Lp(a). That happens to be an LDL particle to which is attached a potentially very bad protein called apoprotein, not capital A, which is on an HDL, but small case, not a lowercase a, lipoprotein a. That comes from the guy who discovered it, said, I've just discovered an antigen. So he called it LP antigen, Lp(a). That's where the name comes from. So as it turns out, ApoA, if your liver makes it, it jumps on LDLs that the liver is making, and then it secretes a new type of LDL particle called lipoprotein a. For a lot of reasons, it has way more atherogenic potential than does an LDL particle not containing ApoA. So the belief has been, God, if we could just lower Lp(a) levels, we would take that lipid disorder off the chart as a non-issue anymore. Now, there are a couple of drugs in development that will absolutely shut down ApoA manufacture in the liver. Several years before we're going to see any of them go through their safety trials and outcome trials that they'll ever come to market. Once they do come, God knows what they'll cost. Anyway, the people being studied now are nightmares. People who have extensive heart disease. There's not a primary prevention trial, so to speak, going on yet. But here's the good news. When the liver makes apoprotein a, it travels through the cytosol and then it binds to an LDL particle, creating Lp(a) particle. Guess what is the chaperone that carries ApoA through the cytosol to the LDL? PCSK9. So if we inhibit PCSK9, you will, to some degree, produce less Lp(a) particles. So right now, the PCSK9 inhibitors that are on the market will about 25, max 30% lower Lp(a). You could say that's better than nothing. The new ones coming will just take ApoA out. But now that would be an off-label use of the PCSK9 inhibitor. They're not approved to do that. Third-party payers probably will not pay for your drug if that's the reason you want to use a PCSK9 inhibitor, because the FDA wants outcome data that a PCSK9 current inhibitor, by reducing lipoprotein a by 25-30%, you would improve heart attacks and whatever. All we have right now is from the two big PCSK9 trials, Fourier and Odyssey, each using a different PCSK9 inhibitor, both of which the outcome trials were positive. In those trials, they did lower Lp(a) to the extent I mentioned, and it's sort of post-hoc analysis, but there seemed to be less cardiovascular events in the people where Lp(a) was lowered. So that's basically hypothesis-generating type material. So the future, ultimately, I think will be brighter for people with high Lp(a). Personally, right now, if I had Lp(a), which I don't, I would ask my doctor to use it off-label to help lower my Lp(a), which probably means I have to pay for the drug myself because the third-party payer, and it is an expensive drug if you have to pay for it. So that's the interesting story on PCSK9 and Lp(a).
Thanks a lot for tuning in again to Foolproof Mastery. This was the third part of the Heart Disease Masterclass with Dr. Thomas Dayspring. So far we've covered a ton, such as the link between cholesterol and heart disease, the different types of lipoprotein, reverse cholesterol transport, lipid transport, and a few false ideologies along the way, such as the myth that high cholesterol is always good. The final part of the masterclass will outline a strategy which you could use to reduce your risk of heart disease. The necessary steps you would need to take following a lipid panel. You're in for a real treat. You can support Foolproof Mastery in a number of ways. First of all, please subscribe to our YouTube channel and leave a review on Apple Podcasts with an honest opinion of what you think. We welcome full engagement with our posts. Leave plenty of comments on YouTube and share the podcast with your friends, family and colleagues if you feel that you have learned something new, in order to keep on getting the knowledge out to as many people as possible. Finally, keep on living every day to the maximum, and see you next time for another episode. Ciao.